My name is Pierre Dane. I work with the Western Cape Department of Health and also with an organization called Vitalway. Today I'll be presenting on behalf of the Western Cape Department of Health, and I'll be talking about a system that's been developed here in the province called Catch and Match. So Catch and Match is at a high level a system that is used by community health workers to go out into the community and screen community members for various types of illnesses or health conditions. It's very widely used. There's 250 community health workers from, I think, 5 different non-government organizations out in the field. They've screened 30,000 households. It's 80,000 people in those households, and they've performed 500,000 plus screenings. They're not, as I said, employed by the government, and they're also not on a government IT infrastructure. Excuse me. So, you know, there's a lot of these kinds of community health platforms around. Common ones are OpenSRP, Comcare, Medic Mobile, etc. So, you know, the use of a mobile tool for capturing community data is not groundbreaking. But what we've seen previously over the last decade is that a lot of these community health systems are very siloed. So the data is captured within that data silo. Often the data are not shared with the public health system, you know, the Ministry of Health or the provincial departments of health, and those data are also stored on servers that, you know, could be anywhere. They could be under the desk in the office of the organization that developed the software or implements the software. So you know, the Western Cape is very focused on protecting the data of the beneficiaries of the health system. So there's quite a strong governance process. The networks, you know, the IT networks are very carefully controlled. No traffic is allowed in and out of the network unless it's very carefully vetted. And, you know, there's whitelists for people who are able to access the system, access the internal network, and there are, you know, there's some very robust security around the network, which means it's very hard to get data in and very hard to get data out, which is fine if you're inside and, you know, running reports, but if you're outside and you want to suck in data, it's very difficult. So I'll go into how all that works in a little while. So you know, this is the kind of environment where the community health workers are working. It's very high density urban environments. They use a locally built Android application. So there's just a few screenshots of the app. It works very well. It works offline, of course. And when the community health workers get back into an area where there's Wi-Fi, then they're able to sync their devices and send the data up into the into the platform. So there's also two web front ends. One is a bespoke catch and match front end, and the other one, which is on the right, is actually the Western Cape Department of Health Open Health Information Platform, which is a platform that is used for viewing patients' clinical data across the province and also for capturing data. So the screen that I'm showing there is actually a screen that allows clinicians to refer patients down into the community. So they can assign a patient to a community health worker from the facility. If a patient comes in with diabetes, the clinician at the facility can actually access those non-governmental community health workers and say, I have a patient who is diabetic. Please make sure that you follow up on this patient. So that was the catch part of the ecosystem. The match part is really, you know, where the interesting groundbreaking workflows are. Just a bit of background on the Western Cape infrastructure. So the Western Cape has quite a mature data center. It's a very big SQL Server cluster that pulls in information from a variety of different sources. So all of those sources on the left, data gets pulled in and linked and merged and then stored inside into the internal data warehouse structures. Just excuse me a second. Sorry about that, everyone. Where was I? But yes, the data gets sucked into this system, and then is used to generate various kinds of output reports, and also to populate the single patient viewer, which is used for the clinical management of patients. So this screen is a view of the OpenHIM, which Matthew also referred to. So it's the health information mediator, and this is used as the main entry point for all data coming into the provincial system. So there's only one channel for this information to come into the system, and it comes in through the health information mediator as FHIR documents. So you can see the different messages coming into the system over there. Another very important part of this system is the patient matching. So it's very challenging to match patients that are found in the community to patients that are found in the formal health system. In the Western Cape, there is a master patient index, which has been implemented in the province for many years, and every patient that accesses the public health system is provided with a folder number, which links, which they then use for all subsequent visits to facilities and hospitals. And using that number, we can track the patient's clinical history. It's linked to the labs, to the drugs that are dispensed, to all the encounters and all the episodes that are inferred for that patient. But in the community, there's generally no unique identifier. People generally do not know their PMI number, which is called the Clinicom number. So there needs to be a way of linking those patients in the community to the public health system, and this is done, using a combination of deterministic and probabilistic matching. Using some different kinds of algorithms depending on the context, and the matches are weighted in terms of strength. And when a strong match is made between a person seen in the community and a person that's already in the public health system, a link is made between those two. So there's a system-generated unique identifier that the patient, that the community member gets from that device, from the mobile device, and that gets permanently linked to the PMI number in the public health system. sometimes there's also weaker links. If there's a weaker link, then what happens is the community health worker actually gets a message saying, this person has been seen in the community. We think that they're this person. Please confirm. And sometimes the way that confirmation is done is that the community health worker gets sent a message saying, the last facility that we saw this person, the last public health facility we saw this person at was X. And if the person in the community confirms that that was the last facility that they visited, then they can confirm the match, and then that becomes a permanent match as well. So what this what this linking of community people in the community to people in the public health system does is it allows the closing of a referral loop. So a community health worker can see a person in the community. They can screen them, suspect that they may have TB, undiagnosed TB. They can refer them to a facility. That referral will get sent up into the public health system as a FHIR document, and then that referral can be monitored through the single patient viewer to see if the person has actually attended a clinic, and that referral can be closed, and then that loop is also closed, so that the community health worker is notified that that person indeed did go to a clinic, and that their referral is closed. And all of this is done without sharing any of the public sector personal protected information with the community healthcare worker. So the sensitive information that's been collected by the public health system is kept within the public health system, and it's only the information from the community that flows in one direction into the public health system for patient care. This screen is an example of one of the transactions. So I've blocked out all the sensitive patient information there, but this is a referral. No, this is a match. So this is a message coming back and saying these patients have matched. So a bundle of 500 patients gets sent up to the provincial system, and then a bundle of patient matches gets sent back down to the community health worker saying these are links. So this is an example of a screen in a single patient viewer. So what this does is it shows a number of different clinical data points. So it's lab results, CD4 and viral load. It's the encounters that the person had with the health system, and it's the drugs that the person has been dispensed. So this is a core piece of the single patient viewer. And this is what is used by the clinicians to manage the health of the Western Cape beneficiaries. In terms of technology, the system uses Couchbase. So it's a native Android application developed locally. It uses Couchbase Lite on the Android device, which syncs with Couch Lite on the Android device, which syncs with the Couchbase server. We have a 4-node cluster that sits in Azure. This is outside of the Western Cape firewalls. There you can see some Grafana information about the cluster. It's looking quite healthy. We also have Couchbase giving us information about what's going on, how many messages are being received from the devices, and how many other kinds of queries are being made. And then we also have the OpenHIM dashboard. So the OpenHIM dashboard is showing us the messages that are moving from the external system, so that Couchbase infrastructure and the community health workers, through the provincial firewalls into the provincial data center. Yeah, and that's the end of my presentation. But I'm hoping